Good afternoon, everyone, and thanks for joining in today. I'm Dr. Kim Newell-Green, and I'll be the moderator for today's CMA, California Health and Human Services Virtual Grand Rounds, COVID-19 Updates in Therapeutics. In many ways, we've almost all just participated in a national case conference on COVID-19 therapeutics in the media and on our TVs during President Trump's recent hospitalization. I know I wanted to call my friends who are experts in COVID-19 treatment as I watched and read the news with so many questions. And though we're not going to talk about our president's treatment specifically today, I am thrilled to have Dr. Annie Lutkemeyer here with us to take us through several cases of COVID-19 patients. Dr. Lutkemeyer has been steeped in the literature about COVID-19 from the beginning and will be a great resource for helping us understand what therapeutics we have now, when to consider using them, as well as giving us a look into some of the exciting treatments that are in the pipeline. There was also a lot made of the cost of the president's care and his use of therapeutics that are not widely available. I'm excited today to talk with two state experts who can give us some insight into California's thinking about the distribution of scarce resources and the planning around creating our own store of a variety of therapeutics. We're going to talk a little bit specifically about convalescent plasma today. Their experience at the state level with remdesivir distribution will help us and our state leaders think about how other emerging therapies, like perhaps monoclonal antibodies and even vaccines, will be distributed. So if we can move on to the next slide, we have this is the slide of disclosures for our speakers today. Then we can move on to the next slide and just remind you all that CME is being provided today. So you'll be sent a survey after the completion of the webinar. You have to do that survey in order to get your CME certificates. So our learning objectives you've just seen. We want to become familiar with the therapeutics being used currently for hospitalized patients, when they should be used. We want to be familiar with how to treat and prevent ARDS syndrome and understand the decision making for allocation of scarce resources. We are so pleased to have our speakers today, Dr. Annie Lutkemeyer, Dr. Phil Peters, and Dr. Jessica Corey. And once we've heard from all the presenters, we'll begin a Q&A session. In the meantime, you can submit any questions that you have throughout the presentation by using the question box in the control panel, which is located at the right-hand side of your screen. Now I'd like to turn the time over to Dr. Annie Lutkemeyer. Dr. Lutkemeyer is a professor of medicine at the Zuckerberg San Francisco General Hospital and Trauma Center. She's the co-chair of the UC San Francisco Interventional Clinical Trials Committee, and she's the principal investigator of the COVID-19 Prevention Network. Thank you so much for joining us today.
Thanks so much. Hopefully you can hear me, and I really appreciate being asked to come and speak with you all about what is often a very confusing and rapidly moving field, which is how do we treat and what can we do to try to prevent COVID? And I'm going to do this through a therapeutics lens. I just want to clarify, I'm not the PI of the whole CoVPN, the Coronavirus Prevention Network. I'm the site principal investigator here at San Francisco General, and happy to be a part of that. Next slide. These are my disclosures. Next slide. I want to start with resources so that that helps to frame what is out there, given, as I said, we are all familiar with this being a very fast-moving and hard to keep up with field. So I wanted to share some of the resources that I use. As you may be aware, there are two U.S. guidelines that are available. There's the NIH COVID-19 treatment guidelines, and the link is here, as well as the IDSA treatment guidelines. And these are both updated relatively frequently. I was going to say in real time, but there is no such thing these days. But these are both terrific resources. And I always like when there's two different guidelines that are available so you can compare and contrast, and it's a nice summary of the literature. I also wanted to just share on the right-hand side of the screen the IDSA daily news briefing. So for those of you who are members of IDSA, or if you want to be a member of IDSA, this is something that you get for free by being part of IDSA, and they really send out a nice summary every morning. My email box, as everybody's, is pretty darn clogged, but I actually really look forward to this. It's a very nice summary that is out there. So wanted to share that for others. We also do a bulletin through our division, and I'd be happy to share that information. We send it out about once a week with updates, and that is free of charge. Next slide. So when we think about how you approach treating COVID, I want to just start by framing COVID and the life cycle itself, because where you are in the natural history of COVID informs what our thinking is here. So I think we're all familiar that in the first, week, what's called stage 1 or early infection, this is when the viral load can be quite high, but people often have mild or limited symptoms. People can then progress typically in the second week of illness, although it's certainly not always this way. In those who are going to become ill, this is when we often see it. And this is characterized by a dysregulated immune response that can lead to things like ARDS, hyperinflammation, cardiac, and renal failure. And when we think about what treatments we're going to use, we tend to think of antivirals really throughout the course of disease. Those include remdesivir, convalescent plasma, things like monoclonal antibodies, but these really may be most effective in the beginning of disease when the viral load is high and before this dysregulated immune system has kicked in. Later in disease, when people have become more sick and there's this immune dysregulation, that's when things like anti-inflammatories probably play their largest role, and we'll talk about some of these along the way. We know that COVID is associated with coagulation abnormalities and an increased risk of clotting, and there's really a lot of important work ongoing to understand how we should be handling this. I'm not going to talk about anticoagulation today, except to say that in hospitalized patients, typically most of us will give at least prophylactic dosing to prevent venous thromboembolism, and there's a lot of investigational strategies to look at whether intermediate or full dose anticoagulation is merited, particularly as people become more ill and less mobile. Next slide. So this is just a summary of the life cycle or the breakdown of how people do with COVID. And as we know, the majority or the probably about 40 to 50% of people can have asymptomatic infection and don't even know that they are infected. Probably about a half go on to develop symptoms of this. The majority are handled as outpatients. But about 20%, depending on where you are, will end up hospitalized. Of those, most will do well, but we really fear the 1/5 or so who go on to require critical care support in the ICU. So much of our focus has actually been on the most critically ill patients, appropriately so, but I'm hoping that we can also shift the conversation today to talk about other places where we can treat people. So next slide. We know that we have a lot of inpatient therapies now that are available. Next slide. But we also are starting to have investigational outpatient therapies, and then importantly, some therapeutics to prevent infection, and we'll talk about those today a little bit. Next slide. So let's just take this right to a case, and we can use this to illustrate some of our treatment principles. We will have audience response polling along the way. This is a 54-year-old gentleman. We always see the focus on older patients, but we certainly do see people who are not elderly having admission and serious disease. He's admitted with 7 days of fever. He has a cough, and he is COVID positive. He's febrile to 38.8. He's requiring 2 liters of oxygen, and he has a chest X-ray with the typical infiltrate. And you want to start remdesivir, and we'll talk a little bit more about remdesivir in a moment. So here are my questions for the audience. In hypoxic COVID disease, which of the following is true? Remdesivir should not be given with steroids. Remdesivir has only been shown to benefit hypoxic patients. Remdesivir blocks SARS-CoV-2 entry into cells, or transaminases should be monitored during remdesivir administration as a possible side effect. I don't think I advanced this, right, guys? I'll wait for you to go ahead and, I don't see the, oh, there we go. Okay, so it looks like about a third of you said transaminases should be monitored during remdesivir. There's some questions about the mechanism of action for remdesivir, which we'll talk about, and a quarter think that remdesivir only will benefit hypoxic patients. So let's talk about all of these. Next slide. Okay, so remdesivir can be given with steroids. There's not a drug-drug interaction there, and indeed, we often do this when steroids are indicated in more critically ill patients. We'll talk about the data for use outside of hypoxia, which is limited, but it is there. And we'll talk about the mechanism of action in a moment. But the transaminases should be monitored during remdesivir administration, and the recommendation is to hold if the ALT is more than 5 times upper limit of normal. Next slide. Okay, so remdesivir acts in the SARS-CoV-2 life cycle once the virus has gotten into the cell. So it is not a blocker of cell entry, but it does act to block RNA replication, and this acts on the RNA-dependent RNA polymerase. It's given as an IV treatment for 5 to 10 days, depending on how critically ill someone is. And as I mentioned, we recommend monitoring the liver function tests and holding if the ALT is greater than 5 times upper limit of normal. We know that we can see liver impact from COVID infection, and some people come in with quite elevated liver function tests. So what do the data tell us? They tell us that remdesivir from the most recently updated final report from the ACT-1 study shows that remdesivir shortens the time to clinical recovery from 15 days to 10 days. We saw in the ACT-1 study a trend towards a mortality benefit and, importantly, less adverse events than in placebo. Next slide. So I wanted just to highlight one of the graphics from the recently published full report from ACT-1. Remember, this came out in the end of April, but this now represents the full report to highlight some other areas where remdesivir may work better. So as I mentioned, we always want to give antivirals early. Clearly, there was a signal towards remdesivir being better if it was given within 10 days of symptom onset. There's still an impact if remdesivir is given after 10 days of symptom onset, but it's just not quite crossing the line for statistical significance here. But again, the sooner we can diagnose people and get them treated, I think the better off they will be. And that's one of sort of the principles that we know from treating all viral infections. You're going to do better if you can diagnose and treat them early. What about the baseline oxygen score, oxygen requirement that people have? And this study broke it down into a couple of different categories. And you could see that the people who benefited the most were those who were receiving oxygen, but not high-flow nasal cannula. There was a trend towards an improvement with those in high-flow nasal cannula and not on oxygen, but the most statistically significant benefit was seen in those who were receiving oxygen. You can also see that that was one of the largest groups, so probably better powered to see a difference here as well. Next slide. Okay, well, what about remdesivir in intubated patients? I just showed you in the last slide that there was, looked like you crossed the significance level and that there may not be a statistically significant benefit in intubated patients. And this led to what I think is a bit of a confusing recommendation in the guidelines saying that if you have a short supply of remdesivir, that you could consider not giving it to people in the ICU. I just want to point out that the ACT-1 study was not powered to look at subgroup analyses, and in particular, there are real challenges to interpreting the data on those who were intubated. And this is a nice table from the appendix of the ACT-1 study. And what you can see here is that they color code where people are on these ordinal scales. And 3, 2, and 1 are attaining recovery. So those are people in the blue. And what you can see at the day 29, if people started out intubated, more than 50% of people still had not recovered. So it's a much smaller group that you can look at to see whether or not they have attained recovery. And it looked quite similar. You know, you could say maybe remdesivir is edging out a placebo. But in order to tell the difference between recovery in the two arms, you have to have enough recoveries. And I think one of the flaws of this study is that unfortunately it didn't follow people who were intubated long enough to know what the difference is here. So I think it's not correct to say that remdesivir doesn't help people who are intubated. I think it very well may. I think we like to use antivirals as soon as possible, but I think it is accurate to say that this study is not designed or powered to really let us know how well it worked in intubated patients. Next slide. I did want to make one other comment, which is that how well then does remdesivir work in patients who don't require oxygen support? And we do have the simple moderate study, which let us know that there was a modest improvement compared to placebo in those who received remdesivir. So there is likely still a benefit to people who are not hypoxic to receive remdesivir, but the issue is that it's an IV medication. And so for most patients, if they're not hypoxic, they're probably not getting admitted to the hospital, or if they are, it may be for a very limited period of time. So in general, we've tended to prioritize treating people who are requiring oxygen support to receive remdesivir, but one could make an argument for treating those who are hospitalized who don't require oxygen, because there are some data to support this, and this is currently in the EUA. So what about other investigational antiviral strategies? And I'm just giving you a snapshot here. Obviously, this is a very fast-moving field, and we hope that we'll have many more antivirals available. Well, what about remdesivir for use in outpatients? If this does work in people who aren't hypoxic to speed their recovery, maybe this would be useful. And I know that there's a study that's ongoing, sponsored by Gilead, looking at 3 days of IV remdesivir for outpatients to see whether or not this helps. There's also investigation of an inhaled formulation, but unfortunately remdesivir can't be given as an oral formulation due to some issues with pharmacokinetics. What about favipiravir? This is a drug that's gotten a fair amount of interest. This also has the same target, the RNA polymerase, but it can be given as an oral agent. And there have been several studies that have come out recently that showed that there was a decline in PCR positivity at day 5 compared to control, and a faster time to symptom resolution in several studies. I think we're looking forward to having larger randomized control trials to help confirm exactly what the role of favipiravir is here. I think there's some concerns about the EC50 of this drug and whether we can really achieve the concentrations that we would like to see for this to be an effective drug, but I look forward to hearing more. There's an EIDD 2801 drug that has a different target. So it's a polymerase inhibitor, but it acts in a different way as a mutagen. And this is being evaluated in both inpatient and outpatient studies, and again, very attractive as an oral agent. And because it has a different mechanism of action than remdesivir and favipiravir, it raises the question of whether this could be given in conjunction with these agents, potentially having an additive or even a synergistic role, and we'll look forward to hearing more. Lastly, I just wanted to highlight interferon beta. And interferon beta is part of our body's innate ability to fight off viruses. And very interestingly, it looks like COVID infection helps to impair the type 1 interferon activity in severe disease. And so one of the theories is that if we can give interferon beta early in disease, we may help to reverse this impaired type 1 interferon response. There was some promising data that came out of Hong Kong looking at early administration of interferon, and this is being evaluated actively in the ACT-3 study in conjunction with remdesivir, as well as an inhaled formulation in outpatients in the UK. So we look forward to hearing more about this antiviral strategy. Next slide. So unfortunately, as sometimes happens, this gentleman is started on remdesivir, but his clinical status worsens. He's transferred to the intensive care unit, and he's intubated. So now he has critically ill COVID illness. And I want to ask the question about steroids to the audience. Which of the following is true? Steroids reduce SARS-CoV-2 viral shedding. They've been associated with a mortality benefit in COVID patients who don't require oxygen. They improve the time to recovery in non-pulmonary COVID disease, like those with GI symptoms and myocarditis, or steroids should not be given in pregnancy. Which of the following is true? Okay. Can we get the poll answers? Okay, we're mixed here, so this is good. All right, let's go on to the answers. Or yeah, okay. So steroids actually may increase viral shedding, particularly in severe disease. So that is one of the concerns that's been raised with the use of steroids. So we need to be very thoughtful about how we give them. Steroids have not been associated with a mortality benefit in COVID patients who do not require oxygen, and we'll talk about that data in a moment. We don't know if steroids improve the time to recovery in non-pulmonary COVID disease. We know that people can present with serious GI symptoms and things like myocarditis, but this is not actually known what the best treatment is for these manifestations, including antivirals and things like steroids. And then I did just want to raise the issue of steroids in pregnancy, as this is a little bit of a tricky question. Just to remind you all that dexamethasone crosses the placenta. Hydrocortisone does cross the placenta, but the concentrations are much lower, and that whether or not you want the dex to cross the placenta will depend on the stage of pregnancy, and that this should really be discussed with the treating obstetrician. But steroids can be a good option in pregnant women with severe COVID disease. Next slide. So let's talk a little bit about the data that support the use of dexamethasone and other steroids. The bulk of the data come from the recovery trial, which, as you may be familiar with, is a large pragmatic study that's been conducted in the UK, where they randomized people who are hospitalized, and at one point they had about 15% of the National Health Service admissions were participating in the recovery trial. So it's really been just a terrific source of very rapid and timely information. But it is a pragmatic study, so we have some limitations on what data are available. So they gave people dexamethasone at 6 milligrams for up to 10 days, and this is just showing a snapshot from the publication about what the mortality looked like at 28 days. So starting in panel B, if you look at people who were intubated, you could see that in the Kaplan-Meier curve, there's the best impact or the strongest impact on mortality in those who were intubated, and it decreased the mortality from 41% to 29%. I just want to point out this is a very high mortality. This is not typically what we're seeing currently, and the dexamethasone was given in the absence of remdesivir. So I think in general we are seeing ICU mortality rates of 25% in the most recent publication from Act 1, and even lower in other settings. So it's great to see this mortality reduction, but I just want to point out some of the caveats there. What about those who were receiving oxygen but were not intubated? You could see a more modest benefit here. So there was a reduction in mortality from 26% to 23%. And then lastly, in those who are on no oxygen at all, you can actually see a trend towards a mortality increase. This was low, but it looked like dexamethasone might increase the mortality from 14% not on dex to 17.8% on dex. This was not statistically significant, but it does, again, I think, highlight that this is not a treatment that we think shows benefit in people who do not require oxygen, which typically are people early in the course of disease. And the reason for this is that dexamethasone helps to address the dysregulation we see in later COVID disease. These folks may not have that, and you may be just helping to increase the viral burden without getting any of the the benefit here. So I just want to point out a couple of caveats from the recovery trial, which I think has been very, very informative. In this middle panel, the oxygen only, we don't have any details on the impact of dex by the amount of oxygen support. So as you know, 1 liter of nasal cannula is very different from someone who's on high flow nasal cannula and about to be intubated. So we can't parse out how well dex worked across the spectrum. But I will say that in our practice here at San Francisco General, we tend to not give dexamethasone to people who are just on a low amount of oxygen, who tend to do quite well in general when we give them things like remdesivir, but we do consider it in people who are closer to ICU level care, such as those who are on high flow nasal cannula or have had a rapidly declining course. But we really will welcome more data to understand how steroids should be used in this middle category. We also don't have in the recovery trial, because it's a pragmatic trial, we don't have data on the adverse events that were attributed to steroid use. We're pretty familiar with what the toxicities are of steroids, but again, it's helpful to know, if you're seeing an increase in bacterial infections and other complications along the way. We know we do see more COVID in the setting of diabetes, and certainly dexamethasone can cause a lot of glucose dysregulation. Subsequent to the publication of recovery, there was a WHO meta-analysis and then several randomized controlled trials that came out, which support the benefit in critically ill patients. Several of the randomized controlled trials had to stop early. They stopped early because the recovery data came out, but I think it was very reassuring to see that in general, the trend is in this direction, that there was a clinical benefit or a mortality benefit to using steroids. And some of these studies did use hydrocortisone, not dexamethasone, and it did not appear that there was a big difference between the use of these two. As I mentioned, however, most of these studies were done just looking at steroids and did not have remdesivir on board, so the additive impact of steroids with antivirals is unknown. We certainly hope that it's beneficial. There's not been a signal that it's not, but whether it might be more than additive is unknown. Next slide. Okay. Well, what about other investigational anti-inflammatories that are under evaluation? And there are many. So steroids are certainly a hammer, and they are not specific, and it would be really nice to target pathways that are really affected by COVID and maybe avoid some of the steroid-related toxicities. So baricitinib, which is a JAK inhibitor that is often used in rheumatologic diseases, was evaluated in the ACT-2 trial. We know that there was a press release with top-line data from this study that show a one-day improvement in the time to clinical recovery of hospitalized patients, all of whom were receiving remdesivir and who were randomized to baricitinib versus a placebo. 1 day doesn't sound that great, but as I pointed out with the recovery study, it really may depend on the level of oxygen support. So we will look forward to having more granular data, which we hope will be coming soon from the ACT-2 study, to understand if and when baricitinib may really have an impact and could be considered as a steroid-sparing agent. What about the IL-2 agents? And there's a number of those out there, including tocilizumab and sarilumab. There was observational data published, sort of a meta-analysis, which showed a 12% reduction in mortality. But we know that observational data, while they can be very useful, it's really helpful to have randomized controlled trial data that help to address any kind of physician biases here. And so far, the randomized controlled trial data have been a little bit of a mixed bag for the IL-6 inhibitors. The IMPACTA study came out recently and showed a reduced progression to mechanical ventilation by about 6 to 7%. There was no impact on mortality or time to recovery, but importantly, they didn't look like there was an increase in infections. The COVACTA study, which had a similar trial design, did not show any difference in clinical status, although they did have a different endpoint, which was the change in ordinal score. They didn't see a difference in ventilator-free days or in death by week 4, so a little bit less encouraging. And then sarilumab, which is a different agent, has had several studies now released, which showed negative phase 2 and 3 data. So I think we're in a bit of a holding pattern with IL-6. The data thus far have been a mixed bag, and the current guidelines state that they should not be used outside of a clinical trial while awaiting more data. Anakinra, which is an IL-1 blocker, was used a lot in the early days when there was not data, and this was used in some clinical centers. Also states that the guidelines both say that there's insufficient data to support the use. Many, many more targeted anti-inflammatories are under investigation right now, so we will stay tuned to understand how these work. Next slide. Okay. What about convalescent plasma? We heard a mention of this in the introduction. Just a reminder that this is the antibody-rich part of the blood without the red cells from a person who has recovered from a disease. The idea behind convalescent plasma is that it may reduce the pathogen burden, but it also might have some anti-inflammatory activity. This is one of the earliest infectious diseases treatments that we've had. We've used this for over 100 years in a variety of diseases, some in which it has worked well and others in which it has had less robust effect. In COVID, observational data suggests benefit when it's used earlier in disease and with high antibody concentration, and the FDA has provided some guidance about when convalescent plasma is used, what the antibody concentration should be. Unfortunately, though, we still lack definitive randomized controlled trial data for use, although these are underway. Recently, there was a press release from an Argentina study that showed no benefit of plasma, but again, it was not peer-reviewed. We don't have the final data, so we're looking forward to that. And as I mentioned, the recovery trial, which enrolled a large number of patients in the UK, has enrolled more than 1,000 patients into the convalescent plasma arm, and we look forward to having data. There are also some pooled data efforts that are ongoing to pull together a number of ongoing small studies, including one that we have at UCSF and San Francisco General, to try to understand the impact. So I think the time is long overdue for us to really understand in whom convalescent plasma is working and how we should best use this resource. Next slide. Okay, so what about the outpatient setting? This is a 35-year-old woman. She has some myalgias, loss of smell and taste, which can be classic signs of COVID infection. She's had a mild cough for 4 days, and she tests COVID positive. She does not have any hypoxia, and she's clinically otherwise fairly well and has no indication for admission. So what are the goals of outpatient treatment? We want to reduce symptom duration. We'd like people to feel better sooner. We'd like to decrease their risk of being hospitalized and get them, keep them out of that smaller percentage who end up in the hospital and become critically ill. And in a perfect world, we'd like to see that we could reduce the cycle of infection and break forward transmission. We know with diseases like HIV and viral hepatitis that treatment as prevention has been quite effective. I'm not sure that we'll be able to treat enough outpatients to make a large dent in the epidemiology of COVID, but we certainly can reduce micro-infections within the home and within known contacts if we're able to get a hold of people early enough, and if treatment does work indeed to reduce infectivity, which is actively under investigation. Next slide. So what do you tell this person? She's excited about monoclonal antibodies, which have been much in the news as a possible treatment both in the inpatient and outpatient setting. You tell her that monoclonal antibodies can lead to a positive COVID antibody test after infusion, that they're more effective in severe disease than in those who do not have hypoxia, that they're being developed for oral administration, so she doesn't have to get this as an IV. Or like convalescent plasma, monoclonal antibodies do require a blood donation from a recovered patient. Let's go ahead and see what the poll answers are. Okay. All right, let's go ahead and we'll go through these. Okay, so monoclonal antibodies can lead to a positive COVID antibody test after infusion. Typically, we don't test antibodies for patients after they have a known infection, although I know this did come up a lot with the president's care, but it's just something to be aware of, that it certainly can lead to a positive COVID antibody test. What about the use of monoclonal antibodies? Do they work better in people who have severe disease versus those who don't have hypoxia and maybe outpatients? Well, we don't know, and monoclonal antibodies are being studied across the clinical spectrum. They unfortunately are not being developed for oral administration. They can be given IV, and in some cases, for other diseases, can be given sub-Q if the dose can be reduced enough. And I think this will be very interesting to see if we're able to get away with giving sub-Q dosing for monoclonal antibodies. And unlike convalescent plasma, monoclonal antibodies do not require a blood donation from a recovered donor. They are actually produced in a lab. Next slide. So monoclonal antibodies are laboratory-produced antibodies that have a single COVID target. And if several monoclonal antibodies are given together, they have been referred to in the press as a cocktail. So how do you make a monoclonal antibody? I just reviewed this a little bit in the right side of the pane here. Most of these are identified from a person who has recovered early in the disease from COVID-19, early in the pandemic. And then what they do is try to figure out which antibodies are working the best to reduce the viral load. Then they look at what the target is for these antibodies and come up with the DNA code there. And then they insert the DNA into cells that can mass produce these antibodies in the lab. Just a reminder what antibodies do to help block infections, including COVID. Well, they tend to do two things. One, they can encircle the infecting virus itself and block it from entering and infecting other cells. And then the tail end of the antibody also serves as a flag that tags the immune system to destroy these viruses. So really they can work, antibodies work as antivirals to reduce the amount of virus and to reduce the impact of reduce the ability of the virus to enter cells. As I mentioned, these are typically given IV or subcutaneous. They tend to have a long half-life. At this point in time, the ones we have a half-life of weeks to months. The downsides are a risk for allergic reaction, and so in current protocols, patients are monitored for several hours after receiving the IV infusion. As I mentioned, they're being evaluated across the spectrum to figure out where they may work best. They're being studied in inpatients in conjunction with things like steroids and remdesivir. They're being studied in the outpatient setting as a potential one-time infusion to reduce the likelihood of being hospitalized. And then there may be a role here for prevention in people who have been either exposed to COVID or who require pre-exposure prophylaxis due to a time of real immunosuppression. We have a lot of experience with monoclonal antibodies in other diseases, including both infectious diseases as well as non-infectious diseases, such as cancer, the control of cholesterol, and autoimmune disease. Next slide. So what are the data so far for use of monoclonal antibodies? Well, it's still early days in terms of the data that are available to us. The Lilly monoclonal antibodies had several press releases recently, and what these told us is that both the single monoclonal antibody and a combination of two monoclonal antibodies reduced the viral load over the course of 11 days when after being infused. Encouragingly, we saw a reduction in hospitalization in outpatients going down from about 6% to about 1%, and this was statistically significant, although I'll point out that the overall hospitalization rate was quite low. And there are ongoing outpatient studies that patients can access through this link Rise Above COVID here for the Lilly monoclonal antibody study. What about a different company, Regeneron, which has a dual monoclonal antibody combination? Similar, lots of press releases coming out. Interestingly, they found that there was a better response in those who were COVID antibody negative at the time of infusion, suggesting that we might need to further hone our approach with monoclonal antibodies to understand if someone is antibody positive or negative. Similar to the Lilly monoclonal antibodies, there was a reduction in viral load, and they did report a reduced time to symptom improvement in those who received the monoclonal antibody. In general, they are well tolerated. They reported a rare risk of allergic reaction in the protocols where they're being actively studied. And both companies are seeking emergency use authorization from the FDA for the ability to provide these outside of clinical trials, and we will see where those applications take them and where what the availability is if and when those EUAs are approved. Next slide. Okay. So lastly, I just want to finish up by talking about prevention of COVID and what our tools may be here. So not an uncommon scenario, a 28-year-old paramedic, she's frequently exposed to sick patients and concerned about her risk of developing COVID. She really wants COVID prevention that she can take in addition to the standard infection control measures, masking, PPE, social distancing when that's possible. So what do we have on the radar here? Next slide. We have a number of different strategies. There's pre-exposure prophylaxis, if you can really isolate highest risk points of time, post-exposure prophylaxis after high-risk contact, and in those who are at higher risk of complications. And then obviously there's the strategy of vaccination. For pre-exposure and post-exposure prophylaxis, there was a lot of interest in hydroxychloroquine, which I think several well-done studies thus far have showed us has not led to a reduction in COVID or COVID-like illness. But there is exploration of convalescent plasma and monoclonal antibodies for both of these indications. But I want to spend the rest of the time talking about vaccination and what this might look like. Next slide. Next slide. So before we jump into talking about vaccines, what can you tell her about COVID vaccination? That one, COVID vaccines will likely need to be given every year because of a high mutation rate of the coronavirus, like influenza. That all COVID vaccines under evaluation will require at least a 2-shot series. That COVID vaccines only induce an antibody response, but not a T-cell response. Or that there are no approved current RNA or DNA vaccines that are available, although these platforms are being investigated for the use in COVID. Okay, why don't we go on to the responses here? Okay, so most of you guys got this right, which is there are no approved RNA or DNA vaccines. So we don't know if the COVID vaccine will need to be given yearly if we have an effective vaccine, but if we do, it would likely be because we need to boost it. But thus far, COVID does not appear to mutate nearly as rapidly as influenza. So this hopefully will not be the Achilles heel. We would love to see a universal influenza vaccine, which is under active investigation. But our hope is that the low mutation rate of COVID will not mean that we have to come up with new vaccines on a regular basis. There are one-shot vaccines under evaluation. We don't know how these will work, but we're all very hopeful that this will be a possibility, although many of them are looking at 2. And then importantly, while we are really focused on neutralizing antibody response, and this may be the most important correlate of immune protection, the T-cell response may also play a role in protection against COVID, and some vaccines have shown both antibody and T-cell responses, and we look forward to understanding really what the best correlates of immunity are. Next slide. So I want to just take a minute and walk through sort of the main categories of vaccines under development and talk about where this stands. And I promise I won't do any prognosticating about when they will be available because I really, really don't know. So the first category is DNA and RNA vaccines. And these use a little piece of either the DNA or RNA molecule that is injected into the recipient to sort of teach the immune system to recognize this and to develop a response here. The good part about these vaccines is that they're very quick to make, to design, and to manufacture. So if these work, it would be terrific because we would likely be able to turn them out very, very quickly. However, as I mentioned, these have never been, there's never been a licensed DNA or RNA vaccine, so we just don't know how well this platform will work, but we're about to learn a whole lot more about it. And 2 of the Moderna and Pfizer, as well as Inovio, so Moderna and Pfizer are investigating RNA vaccines, and Inovio is investigating a DNA vaccine. And Moderna and Pfizer are fairly far down the road, and we hope that we'll understand how these work and their safety very soon. Next slide. What about live attenuated vaccines? So this is a weakened version of the actual virus itself, and it's attractive because it stimulates a robust immune response without actually causing serious disease. And you're familiar with this from vaccines like measles, mumps, and rubella, and the chickenpox vaccine. The issue here is that it's not a great fit for those with compromised immune systems, and remains to be seen. You want to be very, very certain that it's not going to lead to disease itself. These are being evaluated by several groups, including Indian Immunologics and Codogenics. Next slide. So the inactivated virus approach uses the whole virus after it's been killed with heat or chemicals. And this is a way of introducing the entire virus to the body without having any risk of it causing an infection. It's quite safe because the virus is dead and it's very easy to make. And this has been used with the polio vaccine, the inactivated version. One of the issues, however, is that completely inactivated viruses as a vaccine approach may be less effective because it doesn't stimulate as much as an immune response. And these are being evaluated by several groups, including Sinovac and Sinopharm. Last 2 approaches here. So here's one. This is subunit approach. So this is basically just taking a piece of the virus's surface to focus the immune system on a single target. This is a very common approach. We use this for the pertussis vaccine, the hepatitis B vaccine, human papillomavirus. And because the immune response is sometimes a little bit weaker, oftentimes we have to give subunit vaccines along with a booster or an adjuvant to stimulate the immune response. And Novavax and AdaptiVac are two of the companies that are looking at the protein subunit approach here. And then lastly, viral vector vaccines. This approach takes a different virus, so not the coronavirus, but a harmless virus, and uses it as the vector to deliver the viral genes to introduce them into cells, and then to build immunity by spitting out usually the spike protein of the coronavirus. And the good part about this is that live virus vaccines tend to stimulate a stronger immune response than either dead vaccines or subunit vaccines. And they have two different approaches here. They could have a completely replication incompetent virus, or one that can replicate but doesn't lead to disease. The Ebola vaccine in the EU uses an adenovirus vector, and there are veterinary vaccines that have used this approach. The adenovirus approach has also been used widely in experimental HIV vaccines, none of which have been licensed yet. And this is an approach that's being done by AstraZeneca as well as Johnson & Johnson. Both of these are gotten a lot of press as part of Operation Warp Speed. Next slide. So what about if you have patients who are interested in being part of vaccine studies? There are many, many different platforms for vaccine studies that are ongoing. As I mentioned, I'm part of the Coronavirus Prevention Network. And what this does is it's tried to include a number of different vaccines that are possible, which are being opened in a staggered way, and people can sign up for the registry, so they don't have to pick one vaccine to be a part of. They can sign up for the registry, and then sites near them can contact them and say, hey, we have this study that's opening. Are you interested? We're going to be looking at X vaccine, and they can say yes or no. It also allows sites to have a large pool of people who are very interested, and that you can pull from that pool to help link them up to the research. So I'm sharing this, but this is by no means the only way for people to be involved in research, in vaccine research, but it is nice because it's a national database that's not vaccine specific to a certain vaccine. It's also available in Spanish on this website. Next slide. So I want to end there. I know that was a bit of a whirlwind tour of therapeutic approaches to COVID treatment and prevention. I've included my contact information here, as well as the email for our unit, and I look forward to taking questions.
Thank you so much, Dr. Luetkemeyer. Annie, we are really grateful for your conversation. We're going to hold off on questions till the end after our next shorter presentation. So we will be concluding this portion, the presentation portion of our webinar, with a combined presentation from Dr. Phil Peters, who's the medical officer at the California Department of Public Health Office of AIDS, and Dr. Jessica Corey, who's the senior medical officer at the CDPH Infant Botulism Treatment and Prevention Program. Of note, Dr. Corey, unfortunately, is not at a place where she can be on video, but she'll be on audio, and Dr. Peters is here with us on video. So take it away.
Great. Well, thank you so much. Thanks for having us here. Dr. Jessica Corey and I, as you stated, both work at CDPH, and we're going to quickly review California's initiatives to allocate and improve access to scarce treatment resources. Next slide. So we're going to start by reviewing the state's role in allocating scarce resources in general. Then Jessica is going to move and provide an overview of the state's initiative to enhance donations of COVID-19 convalescent plasma, or CCP. I will then present the remdesivir distribution program, and we'll consider it as a case study, because then we're going to wrap up and discuss some lessons learned. And hopefully that can provide some insight into how future treatments and vaccines might be fairly and transparently allocated to maximize their clinical benefit. Next slide. Okay, so this slide reviews a guidance document that was actually developed before there were any available COVID-19 treatments. It was developed for hospitals on the topic of allocation of scarce medications for COVID-19. And it was developed based on some guiding principles. It starts with the assumption that new medications to treat COVID-19 are likely to be limited and maybe extremely limited initially. Therefore, we need a process that's both transparent and fair that can prioritize their use. The first step is really to develop a multidisciplinary, evidence-based clinical prioritization committee. This committee can review federal and state guidance and clinical trial results. Based on this committee's evidence review, patients can then be prioritized who have demonstrated, or in a category that would have demonstrated benefit based on these clinical trials. If there is an anticipated clinical benefit that's similar in multiple patients, but only one treatment course is available, then a random allocation may be necessary to fairly allocate which patient should be treated. These decisions regarding which patient to allocate to should not be made by the treating physician, both for the benefit of the physician, care team, and for the patients. Finally, the guidance recommends utilizing regional partnerships to address institutional variation and access to medication. And we saw a lot of really great examples of this regional cooperation with remdesivir. Next slide. And we could move to the next slide. Okay, I think we're stuck on this one, but I think the next slide is going to review the state's role in addressing scarce treatment resources in emergency situations. Here we go. The state can facilitate select medication. I think we went one extra, so you could just back up one. The state can facilitate select medication distribution. Okay, it's going forward. Sorry, everybody, if we could back up 2 slides. And this is what we'll move into. There we go. Okay. All right, now forward. All right, okay, sorry for the technical difficulties. I think we're good now. It says this slide is basically summarizing how the state can address scarce treatment resources. And the state has a number of resources that can help with emergency distribution. One is that the state has a strategic stockpile for emergency response that can be utilized. 2, the state has a network called the Medical and Health Operational Area Coordinators, or MOAC. And this is a network of emergency response professionals within each county who can coordinate access to medications and really a lot of other resources related to emergency response. With COVID-19, we have had situations where the state data was very useful to help ensure fair access to a limited COVID-19 treatment, and this was the remdesivir example. And then we also have seen situations where the state data could be used to increase supply of a COVID-19 treatment, and that is the COVID-19 convalescent plasma, or CCP, example. And so I think that's a good transition and leads us to the CCP part of this presentation. And we could move to the next slide, and I will turn over the audio to Dr. Jessica Corey, and she's going to walk us through a few slides on the state's CCP initiative.
Thank you, Dr. Peters. I would like to lead off by emphasizing that the state's Therapeutics Task Force COVID-19 Convalescent Plasma Initiative was accomplished through crucial partnerships and collaborations with stakeholders. The task force leveraged public health data to accomplish outreach to Californians with laboratory-confirmed COVID-19 to encourage them to consider donating CCP following recovery. We developed an accessible letter translated into 7 languages, which was sent to over 227,000 Californians in a series of monthly mailings. The letter served two purposes: to provide individuals with information on CCP and how to locate their nearest blood center or blood bank. And the letter also served as proof of having a positive diagnostic test for SARS-CoV-2, which was one of the primary donor eligibility criteria, and which the blood centers accepted as proof of positive test. The CCP initiative also included developing an accessible .gov CCP webpage, which includes a zip code county locator for California blood centers and blood banks collecting convalescent plasma. Presently, there are approximately 70 California sites which are collecting or have the capacity to collect CCP. In this process, the task force also worked to overcome hurdles to increasing efficiency and the capacity to collect CCP. This included facilitating this increased efficiency through clarifying California Health and Safety Code requirements, and specifically involved a partnership with CDPH's Laboratory Field Services regarding developing a memorandum to blood centers and blood banks to clarify certain sections of the California Health and Safety Code. We also coordinated with Operation Warp Speed CCP initiatives in that OWS has deployed convalescent plasma coordinators to California Office of Emergency Services Mutual Aid Regions 1 and 6 in the state to facilitate increasing collections in those regions, which have experienced a large number of cases. Next slide, please. I'd like to just go over the web page that was developed on CCP. The address listed at the bottom of this slide is where it can be found on the .gov, covid19.ca.gov website. And again, as mentioned on the previous slide, we did include all of the California blood centers and blood banks in this zip code or county locator, which you can see to the right of the slide. If an individual is directed to this website through reading the letter or through information that we've provided, they can enter their zip code or county and it will pull up in alphabetical order all of the blood centers and blood banks within that area, including links to those blood center or blood bank web pages on convalescent plasma. Next slide, please. I'd like to also briefly review with you the CCP donor eligibility criteria and a little bit of background on collections and what they involve. Eligibility includes meeting federal regulation eligibility for blood and plasma donors. In addition, individuals who wish to donate convalescent plasma need to have had laboratory confirmed COVID-19 and, per the FDA, be symptom-free for at least 14 days. In California, some of the blood centers and blood banks in the state still require that an individual be symptom-free for at least 28 days prior to donating, or have a negative test for COVID-19 in the interim 14 to 28 day period following recovery. Apheresis can take up to 1 to 1.25 hours, so it is longer than a whole blood donation. And the donation volume for convalescent plasma is based on the donor weight and is approximately 600 to 800 mLs per collection. I also wanted to share that AB is the universal plasma donation blood type, though AB blood type does represent a small percentage of the population. The reason it's the universal plasma donation blood type is that it does not contain A or B antibodies and can be safely transfused to recipients of all blood types. At the bottom of this slide, I've also provided resources, including the link to the FDA guidance for industry on convalescent plasma and information from the NIH on blood donor and donation types. Next slide. Finally, I wanted to wrap up by providing information on the guidance from the U.S. Department of Health and Human Services Office for Civil Rights, regarding how healthcare providers can contact former COVID-19 patients about blood and plasma donation opportunities. HHS OCR did publish this guideline back in the spring and then updated it in August to emphasize HCPs can identify and contact patients who have recovered from COVID-19 for population-based activities related to improving health, case management, or care coordination, including contacting former COVID-19 patients about blood and plasma donation opportunities. Without patient's authorization, however, providers cannot receive any payment from or on behalf of a blood or plasma donation center in exchange for such communications with recovered patients. And I provided the link to the detailed guidance on this slide as well. I will now turn the presentation back over to Dr. Peters, who will provide an overview of the California Public Health Medical Emergency Operations System and the remdesivir distribution process. Thank you.
Great, thank you. And so I'm going to pick back up, again, talking about the remdesivir distribution program. And I think it's best understood with a little bit of background on California's public health and medical emergency operations. There in California are 6 mutual aid regions, and in the map that you can see there, these are color-coded. The Regional Disaster Medical Health Coordinators, or RDMHC, work to help coordinate public health and medical emergency operations in these regions. The Medical Health Operational Area Coordinators, or MOAC, is specified in California Health and Safety Code, and there's 1 MOAC per county. The MOACs have many roles. There are actually 17 different core functions that are defined. And one very important one is to monitor and ensure and procure medical and health resources that are needed during either a local emergency or disaster. These roles are appointed by the county health officer and the local emergency medical services agency administrator. Next slide. So this slide reviews the remdesivir distribution process. And I think, as many of you recall, the federal government allocated remdesivir to states based on a formula that used hospitalization data that they were receiving. The state then allocated to county MOACs based on the number of people hospitalized within the hospitals in that respective county. And then the MOACs allocated to particular hospitals. To allocate this product in a fair way that maximizes clinical benefit, we ideally would want a metric that predicts the number of admissions that a hospital will have in a week with patients who have indications for treatment. And we want to know the number of patients who require supplemental oxygen, as that group has the highest level of evidence for treatment. Unfortunately, that data would be really difficult to obtain from every hospital in California. It was not available. What was available was data on the total number of people being diagnosed, data on hospital census for people, total people hospitalized or in intensive care, and also data on new admissions. The data for all new diagnoses seemed to not be specific enough, as was mentioned before, that there are many people who are diagnosed but don't require hospitalization. The new admission data was very appealing, but unfortunately it was not stable enough, and we did not feel like it was accurate enough until about August. So we settled on, as you can see in the circle there, on data for people who are hospitalized with COVID-19 as the metric used for allocation. Next slide. And to be as transparent as possible, this data was uploaded to the CDPH website weekly, and it's still available there, and you can review allocations at a county level, which is seen on the left side. The website there is the link to that document. Or you can review allocations as well at the hospital level, and it has information on all 325 acute care hospitals that received allocations of remdesivir during this process. Next slide. So how did the distribution go? This slide shows the amount of remdesivir distributed per week, and that's plotted in the blue line that you can see, and has a y-axis on the left of the graph, it has a y-axis on the right of the graph that shows the amount of remdesivir distributed. The orange bars are the number of patients who are hospitalized with COVID-19 per week, and that y-axis is on the left of your screen. So as you'll recall, if you could advance one, there is a donation phase during which we're averaging about 3,000 patients hospitalized at any given time, and we were receiving about 10,000 doses per week. Nationally, if we kind of looked at what everybody was receiving, we were receiving the second most amount of medication after New York State at that point. You could advance one more. So unfortunately for us, our surge of infections correlated with the switch to the commercial distribution plan. In the commercial phase had a limited distribution, as you can see, in July and early August. Our number of patients increased to over 7,000, but the amount of remdesivir available was still only 12 to 14,000 per week. At this point, we moved to number 3 nationally in supply, as Florida and Texas both were also experiencing major surges and passed us. The supply finally expanded in mid-August, and that's that large peak that you can see, and you can see all the pent-up demand for the product over a 3-week period was finally met when about 120,000 doses were distributed in that 3-week period. And then subsequently, our hospitalization numbers have come down, and for the time being, nationally, there's now more supply than there's demand for the product. You can move to the next slide. And this slide presents the same data, but in a slightly different way. It looks at the ratio of remdesivir distributed to the weekly census of people hospitalized with COVID-19. And you could advance one more. So during the donation phase, we were going along at about a ratio of about 3, and advance one more time. And with our surge of infections, the ratio went to below 2. And then once the supply opened up, we stabilized at a ratio that was closer to about 6. So closer to about 6 doses of remdesivir distributed per person hospitalized in that weekly snapshot of a census. And that likely, given the current parameters of the EUA, is representing the true demand for remdesivir at hospitals. Next slide. So now we've gone through that process with remdesivir, and we, however, as has been mentioned, anticipate that there are going to be more treatment and vaccine options that are going to become available, but are going to have a very limited supply and will need to be fairly allocated. So what can we learn from this case of remdesivir distribution that potentially could help us? I've listed a few there. There are probably others that you could tell me about, but what I've kind of listed is one, is that data-driven medication allocations are feasible. The data is coming in rapidly enough, but what really facilitated these allocations was the cooperative approach that the RDMHCs had, that the county MOACs had, and that also the acute care hospitals had, that there was a cooperative approach to really be able to visualize that we're all in this together. 2, I think we learned that it is very difficult to define an optimal metric for fair allocation. That could be very challenging, and that we're likely going to continue to be in situations where we have to pick the best of several different imperfect metrics that we can use. And really picking one that can be reliably collected, that we can have confidence in, and can be transparently reported is going to be key. 3, I think we learned that even with the best plans, medication shortages can happen, and they can happen very quickly and unpredictably. Given that distributions are coming in on a weekly basis, they can happen because suddenly the donated supply has been depleted, or because there are very rapid increases in the number of patients who have indications for these medications. And finally, the data is being published rapidly, and we all need to prepare to rapidly define parameters for new medications that come out who are in the early phases of their EUAs, and maybe there is not a lot of data to go on, but we still need to try to define as best we can who are the patient populations that are going to benefit the most. And next slide. And so that takes us to the end of our presentation. And again, thank you for the opportunity to present. And I put on there some of those CCP resources as well, just to show them one more time. But thank you.
Thank you so much, Dr. Peters and Dr. Corey. We'll now move on to some questions. We have a great volume of really wonderful questions, and I apologize we won't be able to get to all of them. I will say that we received a lot of questions about outpatient treatment and how to optimize that, and we do plan a future conversation at this speaker series just about that, so stay tuned. We also, our next month, Dr. Luetkemeyer did a great job of giving us intro to vaccines, but next month on November 10th, we will be doing an entire series with 3 amazing experts all about vaccines. And so we'll get more deep into that conversation next month. And finally, we received quite a few questions along the way about testing. And I just want to remind all of you who are here today that last month's virtual grand rounds was about testing and answers a lot of those questions. And you can still view that video by going to covidroundca.org. So mark your calendar for the second Tuesday of the month, every month from 12 to 1:30. Okay, I'm going to start out with a question that has bits of it for both Dr. Peters and Corey, and also for Dr. Luetkemeyer. So starting, Phil and Jessica, can you comment on how you imagine our supply of remdesivir will change over the winter in the next 6 months? Are you guys making any guesses as we anticipate a potential surge in the winter months? Are you worried? Do you think the national supply is up for that potential surge?
Yeah, I'll jump in, and this is just my opinion. You know, just a crystal ball, I think everyone is anticipating that there definitely is going to be a surge in the winter, that there's going to be a lot more people who are going to require treatment. I think the other force that is happening is, as was reviewed, there are more ongoing trials looking at expanding the indications for remdesivir. So there might be situations where remdesivir is infused in skilled nursing facilities, assisted living facilities, maybe outpatient and doctor's offices, infusion centers. So I think we're both seeing that both the number of patients might increase, the number of indications might increase. Fortunately, the supply has increased quite impressively. So I think for that core group of people that was defined to have the biggest clinical benefit, I do feel confident that there is going to be enough supply for that group. Whether there's going to be a supply for everyone who has been defined to have any clinical benefit, I'm not sure. And so there might still need to be rationing if there really is a big surge of patients moving forward. Thanks.
And Annie, what about, can you talk about in your experience over these months of the availability of the therapeutics that you've discussed? Did availability impact your care decisions quite a lot? And if so, how has that evolved over time, and where are you sort of on that right now? Oh, you're muted.
We did unfortunately go through a time of real shortage of remdesivir, as I think many others did, as Dr. Peters nicely showed, you know, that the spike in remdesivir availability came after the spike in the number of cases, which is understandable but was unfortunate. I think what we all tried to do was really be very mindful of how to best use the resource. You know, if you read the EUA, it says 10 days for people who are intubated or who aren't recovering as well as you would think, you know, are on a slower trajectory. Many of us just cut it down to 5 days total for everybody. And we were prioritizing people who were a little bit sicker and not giving it to non-hypoxic patients as a way to stretch the supply. But we did have some shortages along the way. I think it helps to know that for most people, 5 days is probably plenty. We still don't have good data on whether or not we should extend to 10 days in those who are in the ICU to start with. I don't know that we're going to get those, but I think we certainly, the experience on the ground is that shortening to 5 days certainly it wasn't clear that that was causing grave harm. So there was ways to shortcut, but it doesn't feel great to do that.
Yeah. Yeah, I can only imagine what that was like in places like New York that's had much bigger surges than we have. But I'd love to pivot to a question about cost. Some folks were asking about how and whether the cost of these new and investigational medicines affects both treatment decisions in the hospital. Maybe start with Annie and then Phil and Jessica about how the state thinks about coverage and is pushing for those kinds of things. And then at a national level, what does Medi-Cal cover and how's that all working out over time?
Yeah. So there's only 2 approved therapies right now. There's dexamethasone and other steroids, which are very cheap, but they're, we have a limited window when we want to give those. There's remdesivir, which was free in the beginning because it was donated, but there were supply issues. Now it's about, as I understand it, about $500 a vial, so it leads to about $3,000 for a 5-day course, which is expensive. It's certainly not the most expensive medicine we have. It would be double that if a 10-day course. I think that's how they do it. So it's certainly, we're certainly mindful of it, but most of the decisions along the way, at least in our practice setting, have not been driven by cost. This is an incredibly costly disease when people are critically ill. So, 1 day in the ICU, I don't even know how much that costs, but it's a lot more than $3,000. So if we have treatments that can keep people out of the ICU and prolong their lives, I think that those will be, really prioritized. We'd like to have treatments that work even better. Remdesivir is good, but it certainly doesn't, send people out of the hospital day 1. That's great. They're cured. That may be unrealistic, but we'd like to see adjuvants or even more potent antivirals that help. But for right now, I don't think that the cost has been the main driver, although certainly if we're expanding it lots, and I welcome hearing what Dr. Corey and Dr. Peters have to say, it certainly starts to add up. And I'm not clear on how the payment is being handled. I'm just writing the prescription, so that we need the folks on the back end to tell us how this is being handled.
Thanks. And Phil or Jessica, any conversations? Any thoughts about that? And really, how is the state thinking about equity as new, what I imagine will be much more expensive therapeutics come online?
Yeah, great question. I think with remdesivir, I think it's relatively straightforward at this point, and it's covered by Medi-Cal, it's covered by all insurance companies. It's compared with the total cost of hospitalization, it's a relatively small part of that bill. And there is Federal Care Act funding as well for situations where there's no reimbursement. So there shouldn't be it. The price tag is out there though, and so I do worry that people see it and get kind of worried, especially in situations where they're worried that the patient has less income and there might be some reluctance. But I think we would strongly encourage its use whenever it's clinically indicated. And sometimes funny things do happen where people are stuck with a bill where they're not supposed to get a bill. So if that's the case, it should be covered. And so we would want to hear about those situations so we could help resolve it. So there will be more expensive medications. The monoclonals, just based on how much they cost to treat other conditions, you would expect that they would be expensive. However, Operation Warp Speed in the federal BARDA program has committed to buy all of the initial allocation of those medications as well. So there should not be a cost for those medications either. We probably eventually, because I don't think anyone thinks that even after a vaccine, COVID is going to completely go away. So we likely will probably have a longer term situation where people, hopefully at a much lower rate, are being hospitalized. And I think those conversations, we definitely want to ensure that there's going to be access to the whatever medications kind of shake out as being the most potent and the best kind of moving forward after this emergency phase. The issue of health equity, I think, is a great one. And so I think for the next, I think we're all anticipating that monoclonal antibodies are likely to be the next agents that need to be fairly allocated. And so we're trying to think proactively about how we can ensure that people who have the highest risk of mortality, and I think the groups are older Californians, people who are in SNFs and assisted living facilities, and then Latinx, Black, Pacific Islander Californians. Those have kind of consistently been shown to have groups to have the highest mortality. And we're trying to figure out how we can arrange the allocation so that those groups are going to have equitable access to these new treatments, that they can benefit from them as well.
Great, thank you. Maybe we can move to a real nuts and bolts question, Annie. Some folks are wondering about steroids, dexamethasone, and sort of what's the length of treatment, and then specifically how for providers who are more on the outpatient side, how should a patient be monitored when they're discharged? What do you recommend regarding thinking about the possibility of a rebound of symptoms as they're being weaned off? Any comments on that?
Yeah, so it's 6 milligrams of dexamethasone was what was studied in the recovery trial, and that's equivalent to about 40 milligrams of prednisone. So it's a moderate dose. They call that low dose, but I don't know, I consider that kind of moderate dose. In the recovery trial, if I have it right, I think the median was about 6 to 7 days, even though they offered it for 10 days. Typically, we have not continued it when patients have been leaving the hospital because they're well enough to go. And we have been making a decision, and we would welcome evidence for this, but we're using our clinical judgment at this point, which is sometimes the best we can do, about whether even to complete the full course when people are in-house. If they're really doing a lot better, and if they have any ongoing side effects such as weakness or a high blood sugar or hard to control diabetes, we'll often consider stopping the dexamethasone because it may be more harm than good. Clinically, we have not seen a lot in the way of steroid rebound when we've stopped. It's certainly a consideration, but I'd welcome hearing what others' experience has been, but we have not seen that in the patients when we've stopped them in-house, and usually we are not stopping them until we really feel confident that they are doing well and they're really out of the woods. Some people are really quite sick. They've finished their 10 days while they're in-house, and we stop, and it doesn't look like again, we have not seen a real rebound at the end of those 10 days. But I think that's an area where we need to really understand it more. But I think typically we're not seeing a whole lot of steroid use outside of the hospital, even on a continuation basis, but I suspect that that's a clinical practice style.
Great. And then given the data that about steroids may be worsening disease in patients without an O2 requirement, I presume you wouldn't recommend starting it on outpatients.
No, I really would not. I think that's worrisome, and frankly, we're not generally giving it in people who are only on like 1 to 2 liters of oxygen. Those are folks who often will do quite well and be able to leave the hospital. Some of them will declare themselves and get much worse, in which case we absolutely would give them steroids if that's the case.
Mm-hmm. Is anyone talking about a role for inhaled steroids though, and more localized treatment?
Some of that has been investigated. I haven't seen the data on that yet, but yes, a lot of interest in delivering drugs directly into the lungs, anti-inflammatories into the lungs, to see if that's the best way to get to where you need to go. I think one of the issues there, though, is that this is clearly a systemic disease by the time people are hospitalized. So it's not just a lung disease, and so we'll have to sort out if you just did an inhaled antiviral, what about the other consequences in the body? Maybe you can get away with that if people are only mildly ill. We'll find out. Right.
So it sounds like you would say to an outpatient clinician right now, wait and see for the data on something like trying an inhaled steroid.
Yeah, no, I would not use inhaled steroids. I wouldn't stop them if someone's on it for asthma or for other indications. I would continue those. I wouldn't stop it, but I wouldn't start it as a workaround there. I don't think we know how that will work.
Okay, and we're seeing a lot of other ideas of therapeutics, and so I'm just going to go through this list that people have sent in. Maybe you can give kind of a one-liner on each of them. What about the vitamins, vitamin D and zinc?
Well, I'll say with vitamin D, a lot of interest here. I am an infectious disease doctor and did a lot of work in TB early on, and TB was always associated with a low vitamin D, and so everyone postulated that if we just gave vitamin D, it would keep people from getting tuberculosis or would make them get better more quickly. But when we actually did the studies of randomizing people to vitamin D, I didn't do them, but when colleagues did, it hasn't really panned out as an intervention. All that being said, vitamin D is not going to hurt most people as long as it's not taken in super high quantities. I'm a little skeptical about this as an intervention in the long term, but I always want to ask the first question, is this going to hurt somebody by a drug interaction or by being toxic? And I don't think vitamin D is going to hurt people, but by and large, for most disease states, I have not seen it pan out, unfortunately.
And what about statins? There's some talk about statins.
Yeah, so statins, again, a lot of interest in statins. I would say I think the jury is still out, and that the guidance from most of the guidelines from both the COVID side and the cardiologist is don't start a statin to prevent COVID or treat COVID, and don't stop a statin. Same thing with ACE inhibitors. A lot of discussion about whether or not ACE inhibitors might make you worse or might make you better. And I think until we really have more very clear data, I would use the treatment guidelines for use of statins and ACE inhibitors based on their cardiovascular, risk factors or other things. But I wouldn't start or stop either as a treatment or a preventative.
Okay. And we hear a lot about coagulopathy, of course, and we'll talk about that in another session of this as well. On the outpatient side, any role for low dose aspirin?
We don't know, and yes, we know that there is coagulopathy that can be associated with this disease. Again, it's risk versus benefits. Aspirin in general is pretty safe. People do well with it, but occasionally in someone can get unlucky and have something like a GI bleed or other kind of a bleed. So I think it makes sense. It's probably a low harm intervention in the month after being released from the hospital or having COVID, but we just don't have the data that we want right now. But I would have that discussion on a case by case basis. Aspirin's pretty darn safe. I don't think it's going to hurt people. I do worry when I see people considering full dose anticoagulation. We've certainly seen people have issues. These are being studied in a rigorous way in inpatients, so that we can understand the risks and the benefits here. But I think we need to know better what to do. But giving prophylaxis, thromboembolism therapy for inpatients, I think the data thus far suggests that really probably does make sense and is the benefits outweigh the risks.
Okay, great. And then I think we have probably time for one more question. What about, is there any sort of strength for evidence yet in therapeutics and their different use for different demographics, ages, ethnicities, and race?
It's a great question, and we know that this disease doesn't affect everybody the same. We know that the majority of the mortality is in people who are older, which isn't to say that we had younger people die, but the majority of the deaths have occurred in those who are older. And we obviously know that there's been big ethnic and racial disparities in terms of who's affected and who does poorly. I think we still aren't at a place where we understand where we might with things like antihypertensives, where we're able to say, wow, we've studied these and we understand that this works better in Caucasian populations versus African American populations, potentially due to some underlying biology. I don't think that we are there yet, but it certainly would be of interest. And I think just as a corollary that we're very worried when we see older patients, any comorbidities, because those are the folks who can just do poorly quickly.
Great. Well, unfortunately, that's all the time we have today, but I'm very grateful to all three of you for being here today with us, and to everyone listening for joining us today. And please do come back next month. I also want to share that CMA does provide many other webinars and resources, this is the CMA Telehealth Tipping Point Project that has several webinars as well, and you can find additional information at cmadocs.org/telehealth webinars. Just a reminder, by the end of the day, you'll be sent a survey where you can attest to your attendance, and this is necessary to be sent your CMA certificates, in which you'll get them in one business day. That email will also remind you where to access the recording of the webinar, and please do share that with any colleagues who you think might benefit from it. Registration for all of our things are on covidroundca.org. Thank you, everyone, and have a great and healthy day.